Welcome, everyone, to this deep dive, focused specifically for plastic surgery trainees hitting the books for board exams. We're going straight into the core stuff today. Microsurgical reconstruction. It's interesting how it's shifted, hasn't it? From maybe a last resort to often being a first-line choice, the reconstructive elevator for complex defects. Our aim here is a really direct review of what you need for the exam. Indications, contraindications, kit, techniques, post-op care, the essentials.
Exactly. Let's start with the why. When is microsurgery actually indicated? Think about those big composite wounds, things like mandible reconstruction after cancer or covering major open fractures. These are situations where, well, simpler local options often just can't restore both the form and the function adequately.
Right, because you need to bring in complex tissue from elsewhere.
Precisely. The big advantage is transferring composite tissue, bone, skin, fat, fascia, muscle, whatever's needed, to a distant site.
Okay, so beyond those major reconstructions, what other specific indications should trainees have at top of mind?
Definitely hand and digit replantation and reconstruction. That's a classic. Also, functional muscle transfer, say, for facial palsy or brachial plexus injuries. And don't forget vascularized bone grafts and nerve grafts for specific defects where you need that blood supply.
Got it. Now let's flip to the other side, contraindications. We always hear there are a few absolute contraindications in surgery. Does that hold true here?
It really does. There are essentially no absolute contraindications to microsurgery. Extremes of age, for instance, very young or very old, they present challenges, sure, but they don't automatically rule it out.
And systemic disease.
Similar story, not an absolute no, but the crucial factor is whether the patient can physiologically tolerate a potentially long general anesthetic. That's a big part of the risk assessment.
What about hypercoagulable states? That always raises concerns with anything vascular.
Yeah, that's definitely a relative contraindication. You need to be alert for it. A history that raises suspicions, things like recurrent miscarriages or previous GBTs or PEs, warrants a closer look and careful consideration of the risks versus benefits.
Okay, and smoking. The perennial problem in plastic surgery. How does it impact free flaps?
It's interesting, smoking doesn't seem to increase the rate of flap loss itself. But, and this is a big but, it significantly ramps up wound healing complications. We're talking around a 50% increase.
Wow, 50%?
Yeah. So for elective free tissue transfer, you generally avoid it in an active smoker if possible. Where it becomes absolutely critical, though, is digital replantation, smoking afterwards. The failure rate can shoot up to 80, even 90%.
That's huge. So pre-op counseling is non-negotiable there.
Mandatory. Absolutely mandatory.
What if the patient has had prior radiation to the recipient site? Is that a contraindication?
No, actually, it isn't. Free flap survival rates are pretty much the same, whether the tissue bed is irradiated or not. In fact, a free flap is often the best option in these cases because you're bringing in healthy, non-irradiated tissue with its own blood supply, which can really help healing.
Makes sense. Are there technical tips for working with irradiated vessels? They can be tricky.
Definitely. Key things are limit your dissection right around the vessel itself, use the finest suture and needle you realistically can, and consider passing the needle from inside the vessel lumen outwards, inside out, to minimize trauma to the intima.
Good practical points.
Okay,
let's shift gears to the toolkit. Essential equipment. Magnification is obviously number one.
Absolutely fundamental. You need ocular loops, minimum 2.5x for the dissection part. Some surgeons prefer 4.5x, maybe even higher for the anastomosis itself. And then the operating microscope, usually a 200 to 250 millimeter focal length magnification up to 25x, though you're typically working around 10x to 12.5x for the sewing.
Double-headed scopes are useful too, right? For teaching or complex cases.
Very useful. And video output is great. Keeps the scrub tech in the loop. Excellent for teaching, obviously. Some newer scopes even have integrated laser fluorescent angiography ICG to check patency right there on the table.
And the specific micro instruments. What are the must-haves trainees need to know?
Right, the basics. Jeweler's forceps, size number 2 to 5, round or flat handles, about 4 to 6 inches long. Fine-tipped spring-handled microscissors. You need curved ones for dissecting and trimming vessel ends, and straight ones for cutting sutures. A vessel dilator, smooth and fine-tipped, is crucial for gently relieving spasm or maybe correcting a slight size mismatch.
Needle holder.
Yep, curved or straight, usually non-locking. Some surgeons actually just use their jeweler's forceps to hold the needle. It's personal preference. And microvascular clamps. Single clamps for temporary occlusion, various sizes, and adjustable double clamps. These are key for bringing the vessel ends together nicely, tension-free. Important point. They should exert less than 30 grams per square millimeter of pressure to avoid crushing the vessel.
Okay, what about the little things on the field? Background, irrigation.
Yeah, important details. A background material of like a micromat, usually light blue or green, gives good contrast. Irrigation is constant, usually a 3 milliliter syringe with a 27G angiocath or blunt tip. Heparinized saline, standard concentration is 100 units per ml. And topical papaverine on hand for vasospasm.
Anything else?
Little cellulose sponges, microscopic hemoclips for tiny side branches, a bird bath, just a small pot with heparinized saline and maybe some gauze to clean instruments and prevent clot buildup. And saline moistened Maricel spears are good for gently dabbing away debris without traumatizing tissue.
Got it. And the sutures and needles themselves, they're incredibly fine.
They are typically monofilament nylon or polypropylene. Sizes range from 8-0 up to 11-0, but 9-0 and 10-0 are probably the most common workhorses, depending on vessel size.
And needle terminology. Things trainees should know.
Yeah, understanding the basics helps. Cord length, needle diameter, usually 75 to 135 micrometers length, radius, the shape, like 38 or 12 circle. The size refers to the diameter, which dictates the hole size. And the swage is how the suture is attached to the needle.
Okay. Now, something that's become quite common is the microvascular venous coupler. Can you talk about that?
Sure, the GM coupler system or similar devices. It's essentially a way to do a sutureless venous anastomosis using these paired rigid rings. The potential advantages are decreased ischemic time, and the rings act like a stent, holding the anastomosis open.
What sizes do they come in?
Range from 1.5 up to 4.0 millimeters. You can use them for end-to-end or even end-to-side venous connections. And the data suggests a very low venous thrombosis rate, often less than 1%. Plus, the learning curve is generally considered pretty manageable.
Seems like a useful tool. Okay, planning. Success in microsurgery relies heavily on meticulous planning, right?
Absolutely critical. It starts with talking to your anesthesia colleagues. Make sure they know not to put IVs, arterial lines, or even BP cups on limbs you might need for flap harvest, like the forearm for a radial artery flap.
Good point. A no IV sticks bracelet, maybe.
Exactly. Prep widely, you might need an unexpected skin graft, so prep potential donor sites. Think ahead. And don't underestimate surgeon comfort. Your posture matters. Feet flat, right angles at hips, knees, elbows. Keep your back and neck straight. Support your hands and forearms to minimize tremor.
Does caffeine matter? Lots of surgeons run on it.
Generally, routine caffeine consumption is fine if you're used to it. Probably not the day to start if you don't usually drink it. But the absolute key is exposure. Good retractors, maybe self-retaining ones, keep the field dry, position the patient and the microscope optimally. Tip: elastic stay hooks can be really helpful. Oh, and another tip, before you divide the donor vessel pedicle, mark it longitudinally with a pen, a racing stripe. Helps prevent twisting when you move the flap.
Great practical advice. During the actual surgery, what are the core technical principles?
Keep the vessels moist, always. Use that heparinized saline frequently. Handle the vessels only by the adventitia, the outer layer. Avoid grabbing the vessel wall itself to prevent damaging the intima. And the absolute golden rule: tension-free anastomosis. You have to mobilize the flat pedicle and the recipient vessels enough so they come together without any pull. Tension is the enemy of patency.
Makes sense. So preparing the actual vessel ends, what's involved?
First, if the vessel ends look damaged or crushed, you have to cut them back until you see a healthy, normal-looking vessel wall. In trauma cases, you really want to choose recipient vessels that are clearly outside the main zone of injury if possible. Then, you gently dissect off the adventitia for about 2 to 5 millimeters from the end. Look closely for any subtle signs of microvascular trauma. Flush both artery and vein ends with heparinized saline. And crucially, always do the spurt test on the artery before you start sewing.
Explain the spurt test again.
You just momentarily release the clamp on the recipient artery. You want to see good, strong, pulsatile flow coming out. It confirms your inflow is patent before you commit to the anastomosis.
Got it. A vital check. Now, the anastomosis itself. Key points for placing those tiny sutures.
Needle entry should be at 90 degrees to the vessel wall. Take a full thickness bite and always follow the curve of the needle. Don't force it straight. Use square knots, usually 3 throws are sufficient. Place them precisely, but don't cinch them down so tight that you deform the vessel or narrow the lumen. The goal is just to gently bring the edges together coaptation.
And you want intimate contact.
Exactly. If the edge everts and endothelium touches adventitia, that's a setup for thrombus. A useful little trick. After your first throw or two, leave one suture end long. You can use it as a gentle handle to manipulate the vessel for the next stitch.
Smart. What about avoiding catching the back wall?
You have to directly visualize the needle tip as it passes through both vessel walls. After each stitch, quickly glance inside the lumen to make sure you haven't accidentally snagged the opposite wall that's back walling. How many stitches? Enough to make it watertight, but no more. Fewer is often better if the coaptation is good. If you see small leaks after you take the clamps off, you can place extra rescue stitches then.
Okay, anastomosis done. What's the sequence for releasing the clamps?
Release the venous clamp first, then the arterial clamp.
Why that order?
If you release the artery first, you suddenly get high pressure flow hitting a potentially restricted venous outflow. That increases pressure and shear stress on your fresh anastomosis, which could risk thrombosis right at the suture line, a mural thrombus. So vein first, then artery.
Okay, vein, then artery. How do you then check if it's actually working?
The strip test, or milking test, is standard. You gently occlude the vessel just distal to the anastomosis with 2 pairs of forceps close together. Then you slide the distal forceps along the vessel, milking the blood out of that segment. Release the proximal forceps. If the anastomosis is patent, that emptied segment should fill rapidly and completely with blood from upstream.
A visual confirmation of flow?
Yes. And of course, look closely for any bleeding from tiny side branches along the dissected vessel segments and clip or ligate those meticulously.
You mentioned end-to-end and end-to-side anastomosis earlier. Can you briefly compare them?
Sure. End-to-end is joining 2 vessel ends directly, usually when they're similar in size. Common techniques are the halving technique, placing sutures 180 degrees apart, then bisecting the gaps, which is good for minor size mismatches, or the back wall up technique, often using interrupted sutures, which can be good for more fragile or irradiated vessels. Triangulation is less common.
And end-to-side.
That's useful when there's a significant size difference, or if you need to preserve blood flow going down the main recipient vessel. Think like tapping into a larger pipeline. Patency rates are generally equivalent to end if done well.
Any technical points for end-to-side?
Yeah, the ideal angle for bringing the donor vessel into the side of the recipient is typically 30 to 75 degrees. And the ideal size ratio is often around 2.1 recipient vessel to donor vessel diameter. Making the hole, the arteriotomy or venotomy, can be done with a Noble 11 blade or a special eye knife to cut a little ellipse. Or you can tent the wall up with a stay suture and snip it with curved scissors. A vascular punch, maybe 2.5 millimeters, can also give a clean hole. Suturing patterns can be interrupted, starting 180 degrees apart at the heel and toe, or running sutures, often starting with interrupted ones at the heel and toe, and then running down each side.
Okay. When would you need to use a vein graft in microsurgery?
The main reason is tension. If you can't bring the vessel ends together completely tension-free, you absolutely need a graft to bridge the gap. Tension is a huge risk for thrombosis. So vein grafts are for bridging arterial or venous gaps. Common places to harvest them include the volar wrist or forearm, dorsum of the foot, saphenous vein, greater or lesser, or the cephalic vein up in the delta pectoral groove.
Important points when using vein grafts.
Definitely mark the vein longitudinally before you harvest it so you don't twist it when you put it in. And critically, you have to reverse the vein graft. Veins have valves, and if you put it in the wrong way around, the valves will block arterial flow.
Right, reversed vein graft. Essential point. What about dealing with size discrepancies between vessels if you don't want to use a graft? Any other tricks?
Yeah, several options. We mentioned end-to-side anastomosis already. That's a big one. You can sometimes do a sleeving technique where the smaller vessel end is gently telescoped inside the larger one. Patency can be similar if done carefully. Or you can make the larger vessel smaller X size, a small triangular wedge from its wall to effectively cone it down. Spatulation is another option, making a longitudinal slit in the end of the smaller vessel, or maybe both, to increase their effective diameter for the anastomosis.
Lots of techniques in the armamentarium. Let's move to post-op care. Monitoring the flap is obviously crucial. What are we looking for?
Absolutely. Frequent meticulous clinical examination is the cornerstone. You're looking at flap color, capillary refill should be brisk, around 2 seconds, any bleeding from the wound edges, flap temperature compared to the surrounding skin, and the handheld Doppler is vital. Listen for the signals. Arterial signals should be rhythmic, pulsatile. Venous signals should be continuous, like a wind sound.
What are the signs of trouble? Venous congestion versus arterial insufficiency.
Venous congestion usually looks blue or dusky. The flap might feel swollen, tense, maybe see little petechiae. Capillary refill will be very rapid, almost instantaneous. Arterial insufficiency, on the other hand, looks pale, white, maybe waxy. The flap feels flaccid, cool to touch, and capillary refill is very slow or completely absent.
Is the scratch test still used?
It can be a helpful adjunct. A light scratch normal is seeing bright red blood appear gradually. No bleeding suggests arterial inflow problems. Brisk, dark bleeding could indicate venous outflow obstruction. But the absolute take-home message, if you are in any doubt about the flap's viability based on your clinical exam, the safest thing is to go back to the operating room for exploration. Don't wait.
What about other monitoring tools? Implantable Dopplers, tissue oximetry.
Implantable Dopplers, small probes placed on the vein or artery distal to the anastomosis before inset, can detect flow changes earlier than clinical signs, which is good, but they have limitations. False negatives can happen, and there's a risk of kinking the vessel or the probe wire. Often useful for buried flaps where clinical exam is difficult. Transcutaneous tissue oximetry, or STO2, is another option. It's non-invasive, gives continuous readings of oxygen saturation in the flap skin. You get a baseline reading intra-op. It can potentially detect compromise earlier than clinical signs, possibly leading to higher salvage rates.
But clinical exam remains king.
Absolutely. These are adjuncts, helpful tools, but they don't replace careful, repeated clinical assessment.
Okay, flap failure. It happens even in the best hands. What are the success rates usually? And what about salvage?
Success rates in experienced centers are high, typically over 98% these days. But if a flap is failing, time is absolutely critical for salvage. The quicker you get back to the OR and restore perfusion, the better the chance of saving it. You sometimes hear about the no reflow phenomenon. What's that?
What's that?
Yeah, that's when the anastomosis might look technically okay, but the flex still isn't perfusing well. It's thought to be a microcirculatory problem, maybe endothelial swelling, platelets clumping in capillaries, leaky capillaries. Basically, the tissue itself isn't letting blood flow through properly. It's considered potentially reversible, maybe up to 48 hours, but becomes pretty much irreversible after about 12 hours. Another reason why prompt re-exploration is key.
Let's touch on anticoagulants. What's the role of things like aspirin or heparin in routine microsurgery?
Well, the best way to prevent thrombosis is excellent surgical technique. A well-designed flap, good recipient vessels, perfect anastomosis. There's actually no strong evidence from randomized trials that routine anticoagulants improve patency rates overall.
But they are often used.
Aspirin is commonly used, yes. It inhibits platelet aggregation, often given post-op for maybe 2 to 4 weeks. Heparin, well, it's a potent anticoagulant, but it hasn't consistently shown benefit for routine anastomotic patency, and it definitely increases the risk of bleeding and hematoma. Systemic heparin is usually reserved for specific situations, like if you find intraoperative clot or have to revise an anastomosis and suspect an underlying clotting issue. Then you might monitor PTT and continue for 5-7 days. What about dextrin 40? That's quite controversial. It's a low molecular weight polysaccharide thought to help with volume expansion and maybe reduce blood viscosity and platelet stickiness. But the evidence is mixed. Some studies suggest increased complications without clear benefit on patency. Plus, it has risks like anaphylaxis, pulmonary edema, kidney issues, so its routine use has really fallen out of favor in many places.
Okay, so focus on technique first and foremost. Lastly, let's briefly cover microneural repair principles.
Key principles for nerve repair. Always assess the pre-op function carefully. The goal is to bring the nerve ends together coaptation without any tension. If there's a gap or any tension, you need an interposition nerve graft. And importantly, no single type of nerve repair technique has been definitively proven to be superior in terms of functional outcome.
What are the main types of repair techniques?
The standard for smaller nerves is usually an epineurial repair. You use very fine sutures, maybe 10-0 or 11-0, just catching the epineurium, the outer sheath, to align the fascicles inside. Usually just 2 or 3 sutures are enough, placed about 180 degrees apart. Then there's perineurial or fascicular repair. This is technically much harder. You're trying to align and suture individual fascicles or groups of fascicles using the perineurium. Theoretically, it gives better fascicle alignment, but clinically, it hasn't consistently shown better results than a good epineurial repair. And for larger nerves where you can identify distinct fascicle groups going to specific branches, you might do a grouped fascicular repair, suturing those groups together at the inner epineurial level.
And if there's a gap, you mentioned grafts. What about conduits?
Right, if you can't bring the ends together without tension, you need something to bridge the gap. Autologous nerve grafts are the gold standard, commonly using the sural nerve from the leg, or maybe the lateral or medial antebrachial cutaneous nerves from the arm. For smaller gaps, particularly in sensory nerves, up to about 3 centimeters, conduits can be an option. These can be vein grafts or synthetic tubes made of things like polyglycolic acid, PGA. Results can be comparable to nerve grafts for these specific situations. There are also processed human allograft conduits available now, like Axogen. These provide a biological scaffold with microtubules, potentially allowing more organized axon regeneration compared to simple PGA tubes. There's growing evidence for their use.
Okay, fantastic overview. That covers a lot of ground. Crucial for the exams. Any final take-home points to hammer home?
I think the key things are, remember, there are no absolute contraindications. Surgeon comfort and good exposure are vital for technique. Always aim for tension-free repairs, both vascular and neural. And while monitoring devices are helpful, they never replace a good, thorough, repeated clinical examination. If you are worried about an anastomosis, trust your clinical judgment and go back to theater sooner rather than later. Prompt re-exploration is what saves flaps.
Excellent summary. Thank you for joining us on this focused deep dive into microsurgery principles for board preparation. We hope this concise review helps solidify these core concepts for everyone listening. Keep reviewing these fundamentals and thinking about how they apply in different scenarios. Ultimately, achieving successful outcomes in this demanding field hinges on that blend of technical skill, sound surgical judgment, and timely intervention.